Welcome.
The Pathology Innovation Collaborative Community is a regulatory science initiative that aims to facilitate innovations in pathology, as well as advance safety and effectiveness evaluation. The PI Collaborative Community aims to harmonise approaches to speed delivery to patients through collaboration in the pre-competitive space. The PI CC is open to all stakeholders, public or private, including but not limited to academia, industry, healthcare providers, patients, and advocacy groups. Meetings of this kind are an example of lawful activity under federal antitrust law, because the focus of the meeting is on government action or policy, including the industry's responses or positions taken with respect thereto. However, antitrust monitoring is needed for companies' own protection, since they are direct competitors meeting together. These meetings need to stay within protected subject matters and need to be monitored so that they do not stray off into inappropriate areas, such as pricing and price terms, sales and service territories for particular products, customers and customer territories, each company's individual decisions regarding selection of suppliers or customers, marketing plans and especially future marketing plans or new product offerings, other proprietary or competitively sensitive information. Today's meeting will follow the written agenda, and there will be no discussion of pricing or other prohibited topics. If the discussion veers into those topics, we will terminate the discussion. If you have any questions or concerns about the propriety of the discussion, please raise it immediately, and we will take a break to determine how best to proceed. The Medical Device Innovation Consortium acts as the formal convener, and we will follow their conflict of interest policy. For additional information, we defer to our Code of Conduct and our website, www.pathologyinnovationcc.org. We look forward to moving the field forward.
All right. Welcome everyone to the third session of the Clia waiver, which is not a waiver, but an enforcement discretion. And today we wanted to talk about what should we do moving forward, or can we somehow create a somewhat of a position paper of what we think is good right now in the change state and what we may want to do moving forward. Joe, you wanted to share something here?
Oh no, I just shared it. It was an aside. It was just we're talking about remote sign out, but I just brought this paper up from the Scottsdale Institute, which is one of those informatics organizations that are out there, and it provides a C-suite perspective on workplace environment, hybrid versus remote versus in person. So it was just kind of interesting seeing it from a C-suite perspective. So I just brought it out there since we're talking about remote work in some ways.
Mm-hmm. Thank you for sharing this. So we had a session yesterday where we talked about, monitors and all kinds of details, but I wanted to switch this a little bit for today, because let's just assume that the current state, which is, a certain degree of enforcement discretion, would be the new norm. And, there are 5 specific rules stated in the memorandum that defer to a total set of about 25 rules. And I put together like a mini sort of overview of sort of the key 6 features within that. And just as a quick reminder again, for everyone who wasn't on the initial call. So we're approaching this memorandum, which is the current state, as, let's just call it potentially the new practice or the future new norm, and whether we want to change anything on that altered state. I don't think we want to go back, or if we want to go back, why, but there's basically what do we want changed here. The 2 things to keep in mind is that the memorandum affects a lot of different things, not just digital pathology or remote sign-out using digital pathology. So there's like these 4 buckets that are partially overlapping. If someone has a better suggestion, please, share that, or we can have a separate session on this. But what I really wanted to focus on today is the following. So as currently drafted, laboratories can choose to utilize so-called temporary testing sites for remote review. So I presume moving forward, we want this utilize, remote testing sites, not temporary. if these 5 rules are fulfilled, so those 5 rules we can branch out, but just briefly, when referring to these sort of individual sections here, it comes down to the standard, of a procedural manual that refers back to a section which is that the specimen should be submitted, etc., which, for digital remote sign out shouldn't be quite that affected. So these criteria, I think most, laboratories that are CLIA certified will have these criteria fulfilled. The other part that's mentioned, which is very important for CLIA and CMS, is the standard retention requirements for all kinds of reasons, medical legal purposes, and to verify in case a second opinion is needed, meaning all the records has to be on file and the typical retention requirements apply. I don't think there's any need to discuss those further, but the establishing and verifying performance specifications and how these apply to the standard procedural manuals, I think we should discuss today. And to make this a little more simple, these are sort of the quick points that I think we had some discussion over. So, of course, we need a standard operating procedure. We need to somehow validate it. And I'm using this, if this is the official terminology for LDTs, it would be establish the performance metrics. But I think everyone knows what I mean with a validation report. We should briefly touch upon how we envision proficiency testing to work for remote sites. Retention requirements we just mentioned. There's probably some competency assessment and whether we want to touch upon the issue of credentialing, meaning should we come up with a rule that, we defer to someone being credentialed to work remotely, and what would that look like? Which is probably part and parcel of the competency. So before we dive into these, do other folks on the call have other suggestions on how to tackle this rather diffuse cloud of issues?
Let me just say this is a great start, if anything. I don't myself, I can't think of anything more at this point. I'm sure it might come up, but thanks for setting the tone and setting the framework on this. I think this gives us a lot to chew on as a start, but I don't have anything extra. I'm maybe other folks in the call have some extra ideas, and this is a great time to put it in.
So the fastest way of realizing any of this without opening Clia, and I don't think we can discuss how to change Clia here, just as one other quick reminder is that currently the biggest issue that would come up is that if you would be dinged by an inspector for testing without a Clia certificate, there's certain exceptions now, and the memorandum is specifically addressing the state survey agency directors to provide the information to everyone who would potentially do a survey and would identify that someone signed out, let's say, in his home office without a Clia certificate. So if we propose to the state officers, so kind of falling in line with what CMS was doing on March 26, 2020, we say one very convenient, fast and efficient way of making these changes permanent would be to follow these rules and specifically instruct the state operations manual, which is much faster to be changed, that the inspectors should look out for the following 5 things that would assess compliance with these rules, right? That would be a relatively quick way to enabling a lot of flexibility while having a lot of accountability on the individual laboratories. Now, that is one suggestion. I'm not saying that that would work, but it's definitely going to resonate with the field by not saying we open up Clia, because that would open up a can of worms for all kinds of things. And then, of course, the scope would be restricted in this particular realm or in this particular group for digital pathology, not for signing out flow or whatever. But that's sort of the, this is like kind of a focus on digital pathology sign out.
What do folks think? I think you cognified maybe what I was thinking too. In a very nice, concise way. I mean, you're working at the points where we have some flexibility. without actually really opening Pandora's box with Clia. So it's almost specifying a little more better in terms of modern times. So we're providing modern context in the areas where we have some flexibility without actually going. And then I guess maybe if we're going to revise anything Clia, is there anything, a word here, a phrase there, that can be tweaked that allows us even more flexibility on our end with like giving the state surveyors, putting out a best practices guideline. Those type of things could be all part of that. And this is something where, the CAP, other organizations can put those parts out without actually affecting the law. You can sort of put out ways to provide surveyors what is the best practice? What is the way that it should be done as defined by digital pathology or molecular sign out or whichever? These are things that we have flexibility. So I really like that a lot. And it does tie in a lot of the conversations we had in the first two meetings.
If CMS decides to take this input and revise a specific section in Clia to account for digital pathology, so be it, right? But I think changing law is more complicated than changing guidance, than changing policy, than changing a state operations manual, which is continuously updated and accounts much more for, state-of-the-art issues. So this modern context, I like that wording. So this would be sort of the scope of putting together a document. And of course, we can flesh this out later, but just to sort of get some bullet points in these rough, so of course, does anyone disagree that the lab should have a standard operating procedure for remote sign out? I presume that that's a given, right? I don't know.
Actually, that's the bottleneck. I remember when Matt had submitted to New York State, that was the biggest thing. People didn't exactly know how to write one. Like, what are the things there? People that are just in the space. And I think there's even been viewpoints about that. The folks that were best positioned had been doing it for many years. So they had all that experience built up to write the SOP. While those that just had to do it for the pandemic, it was starting from scratch. So by providing this as a community resource, I think you've really enabled the community by having these specifications, having them out there.
That would have practical relevance, right? If we could draft, I don't think we need to draft this now, but we can have, a group of people who are interested in this revise it. I think, Joe, your and Matthew's paper provide a great outline of how you organized it, but in some other sites, it could be more of a general framework where people can, add their site. But I like that idea a lot.
Yeah, there's many ways to skin a cat. Not to say the way we did it, it might have fit for us, but there's ways to generalize it that's good for everybody. And it provides an anchor for people to write their own that fits their own locality without being too restrictive.
Mm-hmm.
Hi, I want to say something. I'm Pete Parada. I know some of you in the group. I want to first thank you for taking this on from a regulatory standpoint. So if I understand this correctly, what you're going to do is request the CMS to make this waiver permanent as a first step. And I definitely agree with that, because trying to alter Clia, we'll all be gone by that point, I'd say, by the time we got that done. But I would urge you to maybe keep this a little bit general and not get too specific. So we're requesting that this waiver be made permanent under the following, well, first, why, right? We've got a lot of experience now through the pandemic with remote sign out, as long as we meet certain requirements, which can be, that we follow good laboratory practices that are already established. And also that we meet, federal and state requirements, because they're going to be different in each state. Our state usually lags behind instead of picking up some of these extra regulations, which is sometimes very helpful. I would put in competency. I always kind of lump training and competency. So I think, documenting that, the pathologists have been trained in the system, and then as a separate part, they've been deemed competent. However you do that, I think a lot of that can be defined by local site and individual laboratory directors. Credentialing, I'd be a little bit careful there, because now you're opening yourself up to the Joint Commission, and those practices are going to be local. I'm curious, does anyone have specific credentials for digital pathology?
We do in New York because we got we credentialed ours as an LDT basically for New York State. So our lab is not CAPA accredited. We're inspected by the Joint Commission. So
Okay, so you already, have that.
yeah,
And then
we're different. Yeah.
So then will you be trying to get support from other societies like CAP and maybe present this in a joint way?
Yeah, actually, oh, go ahead, Joe. Go ahead.
So just briefly, this is a community resource. There's a lot of people from the various societies contributing and have already contacted us. They may take some of these suggestions and put it in their own letters or refer to it, but this is no non-binding. This is more like explorational in saying like, what do people think, and can we make somewhat sense of it, right? Like for example, what you just mentioned, training and competency. I like that. Like, the current rules is that the laboratory director would define what that looks like. But then the question is like, are we proposing, biannual competency assessment? I mean, that would be, do we do it for every single one, or should it be a subset of people, right? Those kind of things. I don't know what people currently do in let's say in the next gen sequencing field or in flow. So maybe we can just to put down a couple of points so people understand that we thought about some of the details.
Yeah, this is as Joe said. I was gonna. That's Mirvash had asked that same question too. This is really a public resource that these sessions are recorded and open for people to come back to about some of the ideas. This provides some light about how to navigate this space. We're not saying this is the way to do it, but these are the ideas from the discussion we're having. This discussion, I think, is very informative for those that are really looking into, pursuing which way to go.
Because my feeling, regulatory wise, unless there is a specific, let's say, checklist item that tells you how to do something, it's the laboratory director's responsibility to state what you're going to do and then do it. Now, you can always criticize what you've done, right, as an inspector, say, gee, I don't think that's enough. But then you really need to point to a specific requirement.
But I think this is already relatively prescriptive. I mean, this is pulled literally straight. You can Google this number and you'll find it. This is already relatively well defined, and this is not different from any other LDT or any respectable lab would have this for any of their tests. Or is someone disagreeing with this?
That's good. So you don't need to rewrite that. Right.
Correct, but what we should say is that we should follow established practices for validating, I don't know, LDTs, or I don't know.
Yeah, and this is the part that we can specify further about the validated practices. There's not really a standard way to do it that's general. So we could define it for digital pathology. We could do it for molecular sign out. If you're doing evaluation on the laboratory side, those specifications, the states don't have that guidance. And this is probably where, as domain experts, we could provide that guidance. What does a remote sign out look like in a particular context? And that helps sort of specify the types of things you want to look at when you want to sort of make sure that certain guardrails are put in place.
Toby, Shannon, Sunil, other comments? What do we think about?
I'd be a little bit concerned, the mention of competency. I wouldn't want to raise the bar, begin to add in a lot of additional requirements and details that already are things that are sometimes controversial with current practice. I think that ultimately, for example, if you were measuring competency, is it you're competent to look at a computer and make a diagnosis as opposed to competency and making a diagnosis? Because, I think that, this is not a separate type of pathology. This is simply pathology practiced remotely.
I would say you're competent in using the digital system, because when I look through validation, data, right? If the pathologist makes the same diagnosis wrong on glass and equally wrong on a digital image, we're not really testing the competency of the pathologist. We have other ways that we do that.
I think, Peter, I like your idea because I was just thinking about that too. Toby, you raised a good point. There's a distinction between maybe clinical competency and technical competency. And in many ways for digital, I would say the technical competency and a very minimal bar, not like big old checklist of things, might be something that provides reassurance that, hey, you can use the technology. You're not somebody that's not, using a flip phone and now is forced to go digital. There's a certain minimum bar you can meet from the technical side.
I think only thing I will add is that in technology competency, there is a lot of, uncertainty about, say, like, how do you validate a monitor? Or how do you validate those devices, which in DPA, there was a session that those are technical devices, should not be part of validation. They should be done in a technology manner, but there is no consistency or concurrence as to how to go about doing it.
Yeah, we had a very in-depth conversation about monitors, and that might be into the technical framework, or what's really the minimum amount.
So I think it's probably fair to say that our professional judgment applies that no one would go live without feeling confident. I think what this is more about is how do we monitor it and how do we document it so that if someone comes in and says, did you check, did this alter, like right after 2-3 years of practice, someone, like errors like kind of slip in and, like how do we monitor changes in practice? I think that's more what I believe we should give as an input rather than, like whether you use a 13-inch monitor or like, Harsh, you had a comment?
I just want to play devil's advocate for a moment. We don't have competency in using microscopes. So are we setting ourselves up for more, for a bigger burden? And what do our radiologist colleagues do? I mean, do they have competency in using a PAC system?
We do competency assessment.
Okay.
Like, for example, there's certain requirements depending on what service you sign out. For example, if there's a board subspecialty, if you have a board exam, if you're, typically, before any new attending, I don't know, Enrique, about your practice, but if you get new attending in your practice, you have no competency assessment at all? You have no co-sign out? And
you do that, but it's not a specific competency in using a microscope. It's a competency in rendering a diagnosis. And
I think
we're separating the rendering the diagnosis into digital versus microscopy.
No, I don't think that. Maybe that there was a misunderstanding about how Joe just put it, that there's a technical versus a clinical competency.
Right.
I think that separates that. I don't think we're proposing that we would do anything extra other than documenting that someone is able to, let's say, find the web page, being able to open it and handle the technology. And whether or not someone is competent in rendering a diagnosis from screen or microscope, I think that's part of, I would argue, the validation. Harsh, you raised your hand?
Yeah, hi, thank you. So I'm sorry, I'm just trying to understand from a strategic perspective. I think what we are trying to do is to convince to convince whoever needs CMS, right, who issued the guidance, to make at least some portions of that guidance document permanent. And just from my understanding, the simplest way to do it, I think if we go into too many details about, this needs to be done, this needs to be done, it might get too complicated. Whereas the simple argument in favor of making this particular guidance document or permanent, I agree that we don't want to try to convince Congress to pass another law, right? That's going to not happen anytime soon. But if we can just make this guidance document permanent and say that so the arguments that would be relevant in this case is, number one, collect some data somehow to show that X number of cases have been signed out by Y number of institutions, and maybe we do a glass revalidation for that particular argument. or just show that there have been no negative consequences in this since the guidance was issued. So number one, it has been adopted and it has been successful. And the second should be that, well, now that if we do make this guidance permanent, the digital sign out portion, whether it's flow, digital pathology, microscopy, should be incorporated into all of the pre-existing validation, quality, et cetera, requirements that the labs already comply with. So for example, when we went digital, we had to update our standard QC process. We have to develop new quality parameters to incorporate digital sign-out into our overall quality program. So rather than try to say, here's this new set of things that we want you to do, in which we are really restating existing and reinforcing existing requirements, it might be just simpler and more effective to just make a very simple argument. This thing has worked since it was issued, no harm has come from it, and now we will just incorporate this new practice into our existing quality validation, et cetera, requirements. I mean, what do people think? I mean, I think this would be a much simpler rather than have a long, statement of new things that we want them to issue.
I think everybody's point about that. The summary that I've been getting for the general theme is that we want to make this permanent, but we want to be able to give the bodies that making decisions reassurances. And it's the level of what's the right level of reassurance we can give them without being too overbearing or too restrictive for us, that we allow us to practice. That consistency of reassurance is where we're trying to hash out here. And I totally hear everybody's concerned about it being too onerous, because that is a slippery slope, that is potential. And we should always guide rail ourselves that are in that we want to reassure, but do it at a certain level that it will, allow for adoption to really be more scalable. And I guess, Harsh, you give a nice level. I think if we heard some other opinions as well. This is something that might be argued for quite a while, but I think the general theme of this and what everybody's concerned about is not making it too much. And I think this is something that we can hash out even better. Rather than put it into accreditation and laws about this is the enormous checklist you must do, there are certain things that you can abide by, certain rules, standards that can be, an appendix somewhere else. But as long as you follow those under your own way, that might be enough. So,
Harsh, I think you're clearly able to do an LDT in the AP side. What I think, if you present this to the average anatomic pathologist that may not have a lot of experience of launching LDTs, other than, let's say, a person being the immunohistochemistry lab director, this is already very, very detailed. I just think that in addition to what Joe just mentioned, we don't want it overbearing. We want to provide this also as a resource for people who say, hey, we have a scanner. What do we actually need to do, and what should we pay very close attention to? Not every lab has a full-fledged ISO standard QMS system, right, or quality management system. But here are the things that you should really think about. Because, for example, I don't want to change or make it prescriptive to say, hey, we need to have some sort of credentialing. But we want to point out that credentialing still applies. That's an additional reassurance to the field, also to patients, right? We have patient advocacies look at these pages to just say, look, these are all things that will be in place. We're not touching upon the clinical competency of pathologists. These are still, board certified, state licensed individuals that know what they're doing, right? That's an additional thing, but you should still make sure that your, otherwise clinically competent pathologist is able to use a VPN. I think that's a fairly straightforward thing to ask or demand. But
I agree that adding technical competency it should become automatically incorporated, because whether or not the regulations say so, we kind of make it automatic that someone when they come in and are board certified in pathology and have gone through a training program, they know how to use the microscope. And if a pathologist hasn't used this technology before, we need to train them. We do document always the training for the LIS and the EMR, and it's complies, and that's all because we comply with standard requirements. So I'm just saying we shouldn't try to claim that our guidance is actually proposing new regulation. It should just align itself with existing regulations and say, hey, listen, this is just a guidance for aligning in this new era with existing best practices and regulations. Just the other one comment I wanted to make is that anything we prescribe, we should, of course, we are all in this field of informatics and technology. We are all very much aware that technology moves so fast, and today's state of the art is going to become really outdated. And so we should not, it would be terrible to say the bandwidth should be so much or the resolution should be so much.
We're not doing that.
Right,
Shannon,
exactly.
you raised your hand. Shannon?
Yeah, so first, hi, Joe. First of all, I apologize. I missed the first two meetings, unfortunately, so this may have already been covered. But the way we're trying to attack this is thinking about how does looking through a microscope in the laboratory differ from looking at a digital image in my living room, and then taking those differences and thinking about, okay, what would CMS be concerned about with those differences, and then stating what the mitigations are. So for example, I'm concerned about data security, right? So the mitigation would be, well, we use a VPN. I'm concerned about the difference between looking at a glass slide versus a digital image. So we have training or competency or PT or whatever the mitigation might be. And so that kind of gets to the point that I think Joe was making. We want to try to keep the message as simple as possible. So that might be another way to message this, is essentially, here are the differences, here are the potential concerns, and here's ways we could address those concerns.
Yeah, basically reassure without shooting ourselves in the foot with too much weight. And that's a fine line. It's an art, actually. It's not even a science.
Also, but in other words, if I may summarize this, what's currently being proposed, which is basically, don't ding people if they don't have a Clia certificate, but reassure, like as a state inspector, that they have followed these guidelines specified in the appropriate legal framework, which is basically stating, do we have the appropriate, let's call it LDT, steps in place? Now, what I think, Shannon, what you mentioned is, privacy is something that's not generally regarded as something that we need to mitigate. I mean, in the hospital, it says, lock your monitor when you leave your office or whatever, like rules like that, or in common space, don't run around with the patient record in the elevator. But those mitigation measures may be different when it comes to, let's say, homework. So I think there could be totally a statement from a state officer when he inspects a lab to say, how do you ensure that how did you document that the pathologist working remotely does so in a HIPAA compliant fashion? And I don't want to be prescriptive on how that should be done, but that it should be done, I think we hopefully agree upon that, a certain amount of professionalism should guard that. And so I like that idea, but that is also accounted for in this document by saying, the temporary site complies with other applicable federal law, including HIPAA. So one element, this is one of 5, right? That should be done. Mitigating measures should be documented, right? That's how much prescriptive we should be. But what I thought we want to discuss is there something missing here, or is something already too much? Do we not need to go into this? Because this is, I think, pretty well thought out, I have to admit.
Yeah. There's a couple things that came up yesterday about billing and Clia numbers and stuff. Those are I think there's things that we should talk about perhaps on the reporting side. So the current Clia requirement to have your address, your location, you would hate to have your home address in there. So even if this waiver goes away, we should at least advocate for some things that make it a bit easier I mean, getting a Clia license is not hard, so you could get one from your home without much trouble. But then having to put all these other pieces into the report is painful. So I think maybe we could have a fallback to position to say these are things that we think should happen no matter what happens to the waiver in terms of the remote reporting. So there's sort of details around reporting. There's things that were just mentioned by Shannon and you, Joe, about details around the site, being sure it's HIPAA compliant, guidance for an inspector about what you should have in terms of lighting, or all those things could be general suggestions. And then, as always, already been talked about, there's details around the equipment itself, and the validation of that equipment. So we need, I think, best practices for each of those. But I would definitely look at that fallback position.
Yeah. In terms of, go ahead, Joe. So go ahead.
So maybe one thing about the billing requirements. So the CMS form for, let's say, the claim submission has a locality specified, and that has already been, through the whole telemedicine and effort, has already been changed. I'm just trying to find the document, but we can definitely incorporate this. So there's a specific location. So if a service is rendered, and in this case this would apply to the professional billing through a remote, site, there's a specific locality that has been defined. So I'll find that in a second. That was just a comment, because Eric, what you mentioned about the billing is, of course, that's very important. And
to me, if the waiver continues, you're billing out of the Clia number that wherever the scanner, it's not doesn't matter where the heck you are in the world, you're billing from that one Clia number. So I think we can all agree with that, and so that mitigates against having all these sub states within or sub locales within New York that has different reimbursements, because you'd be billing through that one single Clia number.
I think we could specify that. I guess everybody's hitting the same point. I'm glad they did, because it sets context for maybe what I'm going to say, that, in terms of maybe the Clia number, like where it should be, maybe where the slides are produced and where they're scanned. If they're the same, if they're not, we can decide where that could, but kind of a hub and spoke model. The remote sites being, the little arms, and the hub being maybe where the slides are scanned and produced, or we sort of decide that. But that specification is something that we can sort of help guide upon. That's a specificity that hasn't been written yet, but shouldn't be too hard to agree upon, I don't think.
So this is the section here. This is where the place of service is submitted. So the technical versus professional part, I think that is relatively straightforward, because if the professional services are rendered even in a mix, there are models for this. So one other thing that I wanted to bring up, so just let's assume, because this part of wording this out, in other words, we can probably do also offline. One approach that we could propagate, because what we're addressing is a very, very specific set of people who have very distinct knowledge about how this is done, which is, I pulled this here, which is the, Clia State Survey Agency contacts. So this is basically who this memorandum is addressing. And while preparing last night, I thought this is a relatively small group of people, i.e. one per state. They may have the laboratory contacts. Many of them are actually CAP or ASCP members. But this is a select group of people that we could draw from their intense experience in executing the state operations manual. And maybe we could, after drafting this, address that group in an open letter to say we should have a multi-society joint meeting with this group to really say, hey, look, this is something that not a single group can solve, but we should draw from your experience of what a state operations manual instruction for a complex thing like digital pathology should look like. And here's what we thought. What do you guys think? And maybe that would come to a 20-point bullet-pointed list that may be actually more practical for the labs as well as for the state operation surveyors than, discussing in abstract terms what, policy and advocacy can do. So I just wanted to run this by the group, because that's
profound, actually. I mean, this is really bold, because, states do what they want to do individually. But right now, this is something I've learned in looking at, game theory and microeconomics and all that other stuff. But when there's a void, somebody fills it with something. Now, this is actually a good opportunity for us. States write their own stuff, and some states are better than others about writing this. But this I see as a void. We have a lot of new technology. Nobody's written anything that's standardized uniform. We can sort of make a case to the states, whether this is National Governors Association or whichever that can influence the state policy, that we can fill that void for new technologies and lab testing. If you don't have one, this is one that has been agreed upon by X number of states, and you can leverage the same thing. So there's an opportunity to normalize procedures across states just because this is new. Nobody has figured it out yet, and you can fill that void. And that's an opportunity.
So I don't know if there are opinions about that, but if we draft this, it's public anyway, right? Because that's kind of like the PyCC approach. I think a lot of people from Clia and CMS will look at this anyway. We forward it just like we did the first time around when we, mentioned this. I think, API, ASCP, CAP, we have our contacts. They're in part members. We can just state, look, this is what this group came up with. You may not agree with every single point, but that's sort of a very rough draft blueprint for doing a lot of editing. But I think the voice of the inspectors who are ultimately responsible for, let's say, governing the reassurance that we're trying to provide would be an important voice to hear. I mean, I know that it's a little bit of effort to do this early in the new year, but yeah.
Yeah, this is something where advocacy can come in there. I don't know who regulates the states about the state health inspectors and such, but if you can unify and sort of provide a normalized framework and a resource for all of them, this is an opportunity to be able to make sure that every state does it consistently so that everybody has a target to sort of aim for. You won't be really individualizing it for very nuanced things per state.
Harsh, you mentioned something about the EMR and LIS from home. That there's privacy concerns. Of course, we all open the EMR when we're signing out cases, right, to look up the clinical context, etc. So.
Yeah, I think my point was that, there's greater vulnerabilities if some random person reads text on my computer screen that they're not supposed to, rather than see a microscopic image. That's not going to compromise their privacy as much, unless they go to the label of that slide, which is on the screen as well. So, I mean, I think, again, if all of the stuff that we are proposing is good, but I think we need to state that this is all aligning it with existing practices, best practices or requirements, and that basically reassuring the people who are non-pathologists and might be hesitant, including patients, to say that we really can do this in a safe way, without compromising patient care, because there's all these ways you can, and we can specify that. There's nothing new that we are trying to invent here, right?
Mm-hmm. Yeah, so I think let's talk about it from a lab director perspective, right? Attendings will ask over the next few months, what happens if the waiver, which is not a waiver, but when that disappears? What are we supposed to do? Can we sign out remotely, yes or no? And I think we need to have some sort of guidance framework, like someone mentioned the term checklist earlier. Well, you still have to be credentialed. There needs to be, of course, I think from a lab director perspective, I think, these points here, right, are more laboratory director level elements. Whether you need a specific training, I think we should leave up to the local practice, right? But it should be defined and documented. And then comes the part, well, what does an individual attending need? Do we need to have a Clia license? Well, if someone has one, like Eric, you mentioned, it's not a lot of work to fill out the 3 pages. So some of the attendings may actually have that. But I think this goes into like the realm, what Joe mentioned in some of the API listservs is, now we get into, do you need multi-state license? Once you have a multi-state license, can you work for multiple Clia labs? Once you do that, like, can you, like, are we now disrupting sort of a hub and spoke model into the spokes becoming a hub for 3 or 4 or 5 labs to practice. That may actually not be bad in some, let's call it rural areas, but that may be completely perceived different if you suddenly start needing credentialing at another healthcare institution. Medical legal consequences, right? All of those still apply. So somewhere we have to draw a line, right? I think, Joe, you mentioned the Uberification here.
Yeah, my
So
favorite line.
I think this credentialing is not just prescriptive in terms of restricting us, but it would also set a certain limit to say, look, currently, I don't know if the group agrees, but credentialing is still an issue. It has to happen. And whether you can just sign out a case remotely is not the point. The point is also, are you going to be legally responsible for that case if you sign it out for another institution?
Well, I'm going to tell you that there are already very specific rules by the CMS about credentialing and privileging for telemedicine. So you should review those because they exist. And they do have things like if you're at one place and you're signing out a case for another institution, who's in charge of credentialing and who's in charge of privileging, et cetera. So they do exist.
Yeah, that's actually
Perfect.
also
It's very helpful.
interesting. Yeah, it's an interesting point because the ATA is also working. I've been sort of following them, the American Telemedicine Association. They've been working a lot on the mental health front, and they've, which, you can read it whichever way you will, but they've rolled back a lot of stuff on mental telehealth in terms of state licensing and that. So they had a lot of progression like we did, but for them, they've rolled out a lot and they're trying to lobby to bring that back. But they're also like us trying to figure out how to do it without having a rapid expansion. Putting certain guardrails and reassurances to the public to advocate to enable to bring back all this telemental health that's out there.
So I don't want to jump over the Clia question too much. I mean, it's not just a simple matter of filling out the form and paying the fee. I mean, there are responsibilities that go along with Clia, right? So you need to maintain that Clia certificate. So there's a lot of infrastructure to make sure that they get renewed and the fee gets paid and that kind of thing. You have inspections to worry about because you're now a lab in your living room. And also you need a lab director on that Clia cert, and you can only, a given lab director can only have 5 Clia certs under their name. So we're really struggling on this with, I've got 120 pathologists now, and we're doing contingency planning for what happens if all of a sudden they want to keep working from home and we need to get Clia certificates for all of them. That is a huge administrative undertaking.
I just thought I mentioned that some do have one, right? I'm not saying that we should actually strive to make sure that it doesn't require a Clia certificate.
Yeah.
I think that is, I mean, as written right now in the memorandum, I think the wording is that existing Clia certificates are exempt from that rule, so they accounted for that. So I think that's also a point that I think is well drafted. But I would definitely advocate for not needing a Clia certificate just because of the overhead cost. And, we're in value-based care. I think the Clia certificate itself doesn't add value in terms of the bureaucratic step. What it adds, if you maintain all of this, is that you have someone governing this. But if we demonstrate that we have the appropriate means to reassure quality in other terms, I think there would be, there's no value in having the framed Clia certificate hanging in your home office, is what I'm trying to say. It's a very good point. Like the maintenance cost of that is actually quite intense. Fully agree. What about proficiency testing? Have you guys thought about this? Like spot checks or distributing cases or signing up for like a CAP or other program?
We've subscribed to there's some CAP proficiency testing for digital pathology. So we've ordered our kit for next year already. But that's not, that's just for digital pathology.
Correct. That's
if you want to specifically do proficiency testing for remote, that would need to be a new program.
So there's existing programs for digital pathology. So the question is whether the local laboratory leadership can implement this so that under certain conditions, the remote sign-out person will also look at the slide and, provide that result.
Yeah, I mean, this is a good opportunity for CAP and other organizations to build tools and products for this sort of aspect.
Anyone aware of whether those exist, or are those deferring to local practices like with most LDTs? Shannon or Toby, have you guys implemented something like that? Or?
I mean, we're kind of rolling PT and competency together. The beauty of digital images is you can reuse them. So, you can, blind cases and send through previously reported cases, and have someone review them as if they were new, and then compare to the original diagnosis. And you kind of hit on PT and competency at the same time.
We pull previously, rendered, circled, and diagnosed cases, for molecular testing, and distribute those across pathologists who haven't seen those. Yeah. So that's sort of similar, but
that's an interesting thing. I was just thinking, and this is getting more in the weeds than what I know, but proficiency that I know where there's some reluctance with the competency and going down the rabbit hole of how you sort of accredit or regulate that. But proficiency testing is, Shannon, as you mentioned, is kind of built in competency. So through proficiency testing, you've already tested for competency without actually putting the words somewhere. So in some ways, I wouldn't say you're regulating it, but you're already building it in the process of reassurance. So proficiency testing is a good tool just to assess competency. It's built down without actually going down the rabbit hole of regulating competency.
Well, there's a couple of flavors of PT here too. I mean, so you got the PT of the actual staining happening in your immunostains laboratory. That's kind of a separate thing. And then you've got the PT of, the scanning process. Can we, get a good scan? And then finally the PT/competency of the review itself.
Yeah, so many layers of competency, all the way from the technical side to the professional side.
Yeah.
I think the logically, or at least as it's worded, proficiency testing takes the competency into account because it accounts for the whole thing, including, staining all the way to reporting, and ideally without the people actually knowing that they just did a proficiency test. So it's like that's at least the theory. And so PT is at least, typically done as unknown samples, but competency is formally part of it. So that's a very good point.
Yeah.
So
that's interesting. It's an interesting tool. Yeah, to assess competency. I think that's that's good for the community to hear, that there's tools to assess that. I was just thinking in terms of something that was floated on the listserv too, like spot inspections. If you have a remote site, if a regular comes in, they can sort of take a look at your site and be reassured it's not in Starbucks, for instance, and sort of take a look at, so those things might be also something that could be another tool as well,
Those are, for example, it would be great questions to ask a state inspector, right, or a state inspector community, what they would want. For example, should there be a list in your laboratory of all the attendings and their sites where they sign out or not? I think that's a very practical thing to just say, look, every attending who wants to sign out remotely or who does sign out remotely should specify to what degree they do so. If it's just keying out cases, right, going in the limbs and saying, look, I reviewed 20 cases today and I go in and key those out VPN, that is a different risk than truly remote review of scanned slides, I would presume. But, sort of the degree of, or the specifying what work is done and whether it's done. So those are, at least, I would say that's a fairly simple thing to track. Are you tracking that? Just to the groups who are
tracking what type of remotes, and we're thinking about it. It's not easy. It's not easy because relying on the pathologist to kind of do most of the manual work of recording that thing. So we're trying to find automated ways. We had that discussion yesterday. But let me float out one more thing about going back to incentives and game theory model. But I'm more privy to the opt-in model. So let's say if you have a lab and you're doing remote sign out, and let's say you got 50-50, some that want to do it, rather than putting the mandate that everybody has to go through it, the opt-in, like these are some of the extra things that you might have to do if you want to do remote site, PT, all those different things. But for now, because of change management, the opt-in seems to be a more reasonable approach than sort of coming top down and saying, well, you're part of the lab, you're doing it all now. Because you can imagine the type of resistance that comes from that. But if you're really engaged, you're going to do it.
I mean, the question is, what I think, Eric, you mentioned this earlier. Do we propose that a path report should entail whether the case was signed out remote or not? And I don't mean the sign out, but I mean the full review. Is it this case was diagnosed using digital pathology? And I'm asking the question 50-50. I don't know what's right or wrong. I'm just curious what this group is thinking. Because patient advocacy groups may think about this differently than from a regulatory perspective. But is this something that we need to discuss?
As a first step, sorry.
No, go ahead.
As a first step, it would be great if we can at least be able to capture this data, right? And I don't think right now too many places are capturing whether or not a specific diagnosis was made remotely or on glass. And frankly, in my experience, sometimes I'll begin the process by looking at the digital slide, but then it might be a hybrid where a case has a dozen slides, and I've looked at a few of them digitally from home, and then I come in because I really want to see something using glass, or it happens to be so even in my office, I might look at some slides digitally and some slides in glass. So it might be difficult to actually capture it. It may not be an all or nothing phenomenon. Sort of a related topic that I liked Andy Evans's model. I spoke with him about the implementation because we're probably going to follow that for home sign out, where we will have a hospital issued computer with the right specifications and administrative privileges, and a hospital issued monitor, so that we can at least make sure the remote sign out is happening in a controlled environment or a controlled system, and also make sure that there are certain minimum speeds or bandwidth, internet access that people have. Just because this is early days for us, I'm not sure that the regulations should specify it, but a guidance might be really helpful, much better than just having the Wild West out there, and then it will take care of the Starbucks issue right away.
Right. I would not be in favor of having a report that said that you signed it out digitally. I think that's it's a tool. Whatever you're using is what you use. There may be that may be a bit different than with using an algorithm, an AI algorithm. We have urologists whose patients have come to the urologist saying, "Hey, are you guys doing AI?" Because they've heard about it. It did some AI look at my prostate core biopsies, and that can be a marketing advantage. So in those cases, you may want to put a note saying that this case was reviewed by a supplemental pathologist or an algorithm, and define the algorithm. So those are nuances. Regarding the local sign out and HIPAA issues, I have heard rumors that CMS, when they come in and inspect a remote lab, they want to be sure that there's a lock on the door, of where you're signing out, specific lighting requirements or some security around it, not just a VPN. They want to know that remote office has some degree of security associated with it. So there may be some best practices around that. It may be that you're required to have a photograph of the location of where the monitor is, how that's viewed, and then just put that into a file that says this is the pathologist doing remotely. This is what their sign out site is. As an inspector, if I went in, I would be impressed that documentation was there, that someone went to that extent to show what they're doing to protect patient privacy.
I think those would be excellent points to discuss with the state inspectors, right? Because I think what you just mentioned, Eric, like I presume you have inspected labs, many, right? So you know what kind of the heterogeneity is of getting to view different practices. I think to set this, look, this would be something great. You don't have to do it, but if you do it, that would be a proper way of documenting it.
Exactly.
I
Exactly.
think that's a phenomenal suggestion.
Particularly in a community setting where, we sort of take security for granted when you're in the hospital. You got all that built-in stuff. As soon as you move that to a remote site, you don't have all those protections, maybe a VPN and that's it. So I think it's important to get, at least from the community pathologist standpoint, to say, these are best practices if you're going to set up a remote site.
Well, and you also don't have your in-laws wandering through when you're in the hospital. So, considerations like that too, that, your home office is in some place that's not like, in the main walkthrough of your home.
Of course, those best practices aren't any different than the practices that our colleagues that are outside the laboratory should be following right now. I mean, they're accessing the same EHRs, they have access to they're treating patients, and I have no idea what's if there are any, if any of the new sort of sweeping telemedicine stuff that came in, if there was any additional burden placed on them for practicing remotely beyond, like Eric says, best practices.
That's interesting. I don't know. I guess I don't have a contact at ATA, but maybe that's also another group because they're really working avidly on this space, mostly in mental health. But that's interesting. If you see a psychiatrist or something, I don't recall seeing a lot of certificates around, but I don't know. So.
Well, most of our colleagues do not have anywhere near the regulatory burden that we do. But, there may have been some changes that I missed with COVID.
There are some locations, remote locations, have a hybrid model in the sense that they're looking at the slides digitally, but there may be some paperwork with it, that you're delivered something, some documents. And that's the part that you need to be sure is locked down, a bit better, not strewn across the kitchen table. You may have some particular data elements. You may have parts of the chart that you've printed out. There are other things that are paper related that we still have, access to, and we need to be careful about those.
Hey, Joe, can I float something out too in terms of maybe some follow-up? I mean, it's a shame. I mean, like I said before, we could create a whole seminar series just continuing on this thing. But as a follow-up, I'm curious, in terms of reassurance, how do patient advocacy go if they were to hear these sessions? To take a pulse of how do they feel about it. I think this discussion has been really productive, that they can see that we're very engaged, we're very concerned about these things. And the work we're trying to do is to protect care and them. And I'd love to get a pulse of it. If they were to see this, and I think you have, relationships with a lot of advocacy groups, how would they respond hearing the discussion? And the products that come from this discussion might be able to enforce whatever comes out of this, If a patient advocacy group sees the work that we've done here and they realize that some of the regs and the changes happen from this might give them a lot of reassurance.
I fully agree. I mean, this is kind of like what you just said. That's driving what we're trying to do, right? We want to minimize the administrative overhead and emphasize things that make the care good, better, or maintain the quality also for the regulators, right? So I think we, in terms of order, maybe try to, summarize this. So I sent this around to everyone. It'll be on the web page probably early next week. And then we should approach the state inspectors. And once we have their input, we should probably then go through the ATA and advocacy groups, and of course all our, favorite societies to invite them as well and say, look, we have some blueprint here that's not perfect, but what do you guys think about it? And I think the patient advocacy groups are very, very detail oriented. I can tell you that. Like whenever we say we don't want anything detailed, I mean, they're all over this. So
you can't
perfect.
It out though.
Awesome. This was a great session. Thank you so much, everyone, for contributing, and we get this out as soon as possible.
Yeah. Thanks again, everybody.
Thank you.
All right.